Thank you very much for joining me this morning. I was going to give you a little bit of an overview on BOAS and where we are at the moment. My name is Jane Ladlow, and I've worked in this area for quite a long time now, 15 years. I'm currently doing my clinical work at Hamilton Specialist Referrals, and I'm still doing a little bit of research with Cambridge, but just research now. So I was going to talk a little bit about the diagnosis in BOAS cases because I think this is super important, and part of that now for me is this functional grading scheme. So BOAS for me is a very dynamic disease, so you are better evaluating the animals while they are awake than relying on your imaging or your laryngoscopy when they are asleep. And we'll talk a little bit about management, including surgery and the different options that are around now. So there is a lot of morbidity with brachycephalic syndrome. We know that they typically live 3 to 4 years less than dogs of a similar weight with different head shapes. So if you're comparing, say, the bulldog with the Labrador, what we don't know is the morbidity associated with some of the conditions. So I have concentrated on the airway, and I do get into trouble for that, but the airway is a big topic for me. And I'm totally aware that there are other syndromes as well, such as neurological syndromes, intravertebral disc disease. We also have the skin fold problems and also the ocular problems. My impression is that if you get dogs that are better for breathing, they're often better in the other areas as well. And certainly some of the conformational risk factors that improve the breathing, such as length of neck, should also improve some of the things like hemivertebrae. But that's something that we need to look at in the next few years. The reason I put these radiographs up is that we all talk about brachycephalic upper airway syndrome or obstructive airway syndrome as if it's one disease, but actually the breeds are very different and the lesion sites are quite different amongst the breeds. So for me, a pug is very different to a bulldog, and this is reflected in their head shapes and also their genetic lineage. And you can see on the pug, you've got the nasal cavity really underneath that cranium. So if you increase the nose length in a pug, you're not going to make a massive difference to the nasal cavity. You need to increase the length of the cranium. Whereas in the bulldog, the majority of the nasal cavity is actually in the nasal area underneath the nasal bone. So that would make a big difference. But in the pug, it's the length of the head. And actually in all of the breeds, it's more the length of the cranium than it is the length of the nose. So this is our typical Frenchie, probably the most frequent dog we see affected with BOAS. And these are the lesion sites. So we start off with often very stenotic nostrils. And then behind the nostrils, we have this nasal cavity where you've got these thickened hyperplastic and aberrantly positioned turbinates, which can be quite obstructive to the nasal airflow. And then we go back, and the nasopharynx is often very compromised both by the thickness of the soft palate and also by the width of the nasopharynx, which is related to the pterygoid bones and the base of the skull, which is the original defect in some of these dogs. Now, we've also got macroglossia coming in the bulldogs and the French bulldogs. This hyperplastic palate, I call them hyperplastic now, rather than just elongated, because I think the thickness is as important, if not more important, than the length. And then we go back into the rhinoglottis, and in that larynx, we have got, unfortunately, these little ventricles that can easily pop out. And then we've also got laryngeal collapse, which is typically secondary in your bulldog and your French bulldog, but in the pug, the laryngeal collapse can actually be a primary lesion. And then we've got the trachea. And again, the trachea is different in the bulldog and the French bulldog to the pug. So in the French bulldog and the bulldog, you can have a hyperplastic trachea, so a small trachea, but that trachea is typically complete. So you have a very, very small dorsal tracheal membrane, which means that in the bulldog and the French bulldog, you don't see tracheal collapse. Whereas in the pug, you have a much wider, softer trachea with a very large tracheal membrane, and that's when you see the tracheal collapse. So again, these breed differences that we can pick up. So if we start with the nostrils, these are a Labrador's nostrils. They're very beautiful, and they have an external nostril wing and then this interior alar fold, which we see in our guys as well. And this is a really nice open nostril. The important bit is the dorsal area here. So this is where the airflow goes. So this airflow goes over the alar fold and is directed then over laminally over the turbinate tissue. The ventral bit here is not so important. And that's a problem because many of our brachynostrils look a little bit more like this, and this ventral part is kind of identified as an opening by the breeders, but this doesn't really count. Okay, it's the dorsal part of the nostril that is important. Now, behind that nostril, you've got these chunky bits of tissue called the alar fold, and they go on to form the ventral nasal concha. And in a mesocephalic dog, the alar fold will be mobile, whereas in our brachycephalic dogs, this alar fold is often immobile. So it can be a good centimetre or so long, and it sits there without really moving, and it touches the medial septum. So it's what I call the second stenosis inside that nostril. Now, we do grade the brachycephalic nostrils. This is a grading system, and we based this when we were at Cambridge on Marina Packer's work with Mickey Tivers from the RVC. And we are saying that open nostrils, you've got a clear gap dorsally here. So there is a good few millimetre gap here between the nasal cartilage and that philtrum. And for a mild stenosis, there is a small gap, but there is still a distinct gap between the cartilage and the philtrum. For a moderate stenosis, there is no gap dorsally at all. Okay, so we're looking at this dorsal section. And then for a severe stenosis, there's no gap anywhere. Okay, and typically these are commonly seen now in the male French bulldog. So we're seeing, unfortunately, more and more dogs coming through with moderate to severe stenosis. The other thing I like to look at is the mobility of that nasal cartilage. And a Labrador cartilage will move on active respiration, and this really nice Frenchie's cartilages are also moving. Whereas we're seeing quite a few of these guys. This is a moderate stenosis, and there's absolutely no movement at all on these nostril cartilages. And you can see the skin being sucked in just behind the nostrils here, or the nasal planum, which also indicates you've got quite a marked obstruction there. And we know that the nostrils can cause 60 to 70% of the airflow obstruction when dogs are nasal breathing. If we go a little bit further behind, we're now in the nasal cavity, and this is at the start of the nasal cavity. So this is what we call a five-fold view. And this is the start of the ventral nasal concha here, and then you've got the dorsal nasal concha here. And what we see in some of our Frenchies, particularly, and some of our pugs, is that you get aberrant turbinates. So these are turbinates that are branching and then folding forward and sitting just behind the alar fold here, okay? And I think the rostral turbinates are pretty significant. We also see these caudal aberrant turbinates where the turbinates extend into the nasopharynx. I'm not so sure about the significance of those. And we see some of our Frenchies with longer noses actually have more of the caudal turbinate. So maybe this is a kind of a way of accommodating some of that turbinate tissue. So I'm not sure about the caudals, but I really don't like the aberrant rostrals when they are very occlusive. Now, dogs with a really obstructed nasal cavity will tend to switch to oral breathing very quickly on exercise. So you can recognize these dogs if you take them out, because they'll mouth breathe, and they'll often sound better when they're mouth breathing than they do when they nasal breathe. So they can be quieter when exercising than they are at rest. These are also the dogs that tend to have problems with regurgitation and sleeping disorders and heat intolerance. So this little guy has just done a 3-minute exercise test. And to me, this is excessive panting. And he's also got all the hallmarks of stress in that face. We've got a lot of sclera exposed, and he's pulling up his lips, ears back. So to me, this is quite a stressed dog with actually a very short amount of exercise. And we're certainly seeing quite a few of these dogs coming in with heat intolerance. Now, moving back a little bit, we're now in the pharynx, and we've got these large extruded tonsils, and we've also got this thickened, elongated palate, which slips into the rhimaglottis. Now, just want to point out that many of our dogs, so Labradors, German Shepherds, a whole lot will have soft palates that will overlap the epiglottis, okay? So overlapping the epiglottis is not an issue in itself, but what our guys tend to do is that soft palate sits dorsal to the epiglottis. So it's not necessarily the length, it's also the position, and that might be related in some ways to the bulk of the base of the tongue as well. So it might be that you've got a combination of the palate and the tongue that's causing the issues in these guys. Now, the other thing that we tend to kind of look at is the tonsils. And when you have the dog's mouth open, the tonsils often don't look quite so dramatic. But then if you close the mouth, you can certainly see that they could be contributing to the bulk of tissue in the nasopharynx. Now, when we have got an oversized soft palate, we tend to get a very typical stertorous noise. So stertor is a low vibratory noise, typical of a bulldog. And these guys will also have often difficulties in breathing and swallowing at the same time. So you take them out and you exercise them, and they will produce pools of saliva or froth because they can't manage to swallow when they've got a little bit of an increased oxygen demand or air demand. The other thing that I ask now, which I never used to ask, and it's interesting, is I ask owners if there's any difference in eating before and after surgery. And many people don't pick up an eating issue before surgery. And then after surgery, they tell me that these dogs that were always really slow eaters or picky eaters are really eating very well. So that you think, yeah, okay, interesting. So I think owners can't recognize some of the clinical signs that we are seeing with some of these lesion sites. These are the tonsils again. So open mouth, really nice pharynx here, but the tonsils are pretty big, and then when you close the mouths in some of these guys, the tonsils do look rather dramatic. Now, moving back a little bit, we're now at the larynx, and this is a very nice larynx on the left. These are Gerhard Ochtering's pictures. He has the most beautiful setup in Leipzig, and this is a very nice French Bulldog larynx, and what we've got here is a vocal fold. And just in front of the vocal fold, you have little pockets of mucosa that we call ventricles. Okay, these are the cuneiform processes and the corniculate processes, looking really nice. And this is a typical pug. And the pugs have generally got a softer laryngeal cartilage. And this cartilage is very easy and very quick to collapse. So you get a dynamic laryngeal collapse in the pug, which we don't tend to see in the Bulldog or the French Bulldog. And then we do see this kind of thing in the Bulldog and the French Bulldog. And these are the laryngeal ventricles, also saccules, but the correct name is ventricles, which are reverting. And these can obscure quite a large part of the rim of glottis. Now, when you get laryngeal disease, then you get a high-pitched noise that we call stridor. And it's a little bit like sawing wood. So you can recognize the stertor and the stridor. I've put here irreversible cartilage collapse and poor prognosis. That's in the French Bulldogs and the Bulldogs. So in some of the mildly affected pugs, you do see some dynamic laryngeal collapse, which you only pick up when they're excited or exercised. And you can typically only hear that with a stethoscope. So this is the dynamic laryngeal collapse of a pug. So inspiration, inspiration, inspiration. Okay, this is not laryngeal paresis, this is not laryngeal paralysis, this is purely having excessive inspiratory pressures in that larynx. Okay, and then when we look at the saccules or the ventricles, again, there is a dynamic obstruction and they get sucked up on inspiration. Now, moving back a little bit, I just wanted to mention the tracheal hyperplasia. So we see some Bulldog puppies that present about 3 to 4 months of age, and they have a tiny trachea. So we say a Bulldog can have a trachea that's about 12% of the thoracic inlet, and that's normal for a Bulldog, even though we know in a mesocephalic dog we would expect it to be 17 to 20%. Okay, so we're already making allowances for Bulldogs. Some of these puppies will have tracheas that are about 7 or 8% of the thoracic inlet, and they present early on. They have repeated episodes of aspiration pneumonia. Now, we've backed off treating these aggressively now, so we treat them with oxygen therapy, we treat them medically. I try not to sedate them at all, and actually sometimes I don't even get radiographs of them. I can just palpate them, or sometimes I'm using an ultrasound on that trachea just to document the size of the trachea. And what we're finding with these guys is that if you can get them through the bouts of aspiration pneumonia, many of them don't actually require surgery when they get to 12 months of age, right? So it's not the palates, it's not the nostrils, it's the trachea. and that trachea will accommodate as the animals grow. Unfortunately, some of them you can't get through this stage, okay? And these dogs should not be bred, okay? So if you see a dog that's like this as a puppy, even if it looks better as an adult, it should not be bred, okay? We also see secondary changes, so we see lots of gastrointestinal disorders, so we see the reflux, we see the chronic esophagitis, the gastritis, and we see hiatal hernias. Now, for me, the gastrointestinal disorders are secondary to the airway in the Frenchies. Okay, so in the French Bulldog, I will always treat the airway first, and I will typically do the same for the pug. The Bulldog is a little bit different, and you do see some Bulldogs with a good airway and GI signs, and we also see some Bulldogs that don't respond as well with the GI signs after the airway surgery. Okay, so the Bulldog's a little bit different, but in the French Bulldog and the pug, I will always treat the gastrointestinal disorders by the airway first, and you nearly always get it under control. Okay. Now, we also see sleep disorders, and this is something that I think is becoming a lot more noticeable at the moment because of social media, and you see lots of dogs that are falling asleep sitting up and that kind of stuff. So this is something we are starting to look at now. Sleep apneas in humans is a massive welfare issue. So high morbidity, it affects lots of different areas of the body. You get inflammatory changes, you get cardiac changes, you get depression, you get irritability and headaches. So I think this is something that we haven't really looked at because we don't really know in dogs how to document it so easily, but it's an area we should be looking at. And then obviously we've got that heat stroke and that heat intolerance. Now, disease recognition is super important in my eyes. So unless we know what we are saying is affected and non-affected, it's very difficult to open up conversations with owners and breeders. And for years, I looked at this and it was clinical signs and it was noisy breathing, but nobody really defined what noisy breathing was. And that's where we came and did something about it a few years back. And I think it's useful. So we have a couple of ways that we can look at these dogs now. We've got an objective respiratory function test, which I'll talk about, and then we've got the functional grading, which can be done in 15-20 minutes in a practice situation, which I think is very useful. So this is the whole body barometric chamber, plasmography chamber, and this has got transducers in it and carbon dioxide and humidity probes in there, and the idea is that we can get really nice respiratory flow traces by sitting these dogs in the chambers. I think I've got 3 of them at the moment, different sizes. And many of these dogs do tolerate this really well. So we've got an 80% tolerance rate for this. Some of the big affected Bulldogs don't tolerate it, so they get too hot in the chamber. But most of the pugs and Frenchies you can get to settle, and many of the less affected Bulldogs. And this is super useful because now we've got a way that we can say to the owner, well, your dog is affected, okay, or the breeder, and it started the dialogue, okay. So these are the respiratory flow traces. Below the curve is inspiration, above the curve is expiration, and you also get direct measurements of respiratory times, and we can do peak inspiratory flows and peak expiratory flows. And for a few years, we could look at these traces and say that this is a good dog, and this dog's trace is very similar to a Labrador's or a Beagle's. This is a dog that's got a fixed obstruction, so this could be trachea, it could be nostrils, and often is nasal cavity in the Frenchies. And this is a dynamic obstruction, so this could be nostrils, or it could be dynamic collapse of nostrils, or it could be palate, okay, or nasopharynx. So we could look at the traces and say good, not so good, and pretty bad, but we couldn't actually put a number on it. And then I had a PhD student called Naiche Liu, who I'm still working with, which is great, and she came along and she did quadratic discrimination analysis on these numbers we had, and by looking at 6 of the parameters, we could come up with a numerical score of obstruction, which works for the pugs, the French Bulldogs, and the Bulldogs. And this was a really good step forward because then we could look at things like risk factors for the disease, and we could look at prevalence of the disease in our population, which was the show dogs we started with. So this gave us a very nice way to confirm that we were dealing with disease, which is good because many of the breeders thought that some of these signs that we were saying with disease were actually normal for the breed. So this was the functional grading form we were giving to owners. And on here, we put down the plasmographic parameters. So this is things like T over TI, and your peak expiratory flows over your peak inspiratory flows, and its means and standard deviations. We could give them the probability of the dog being affected with BOAS, but we were also using this functional grading system. And I was waiting for the genetic test to be available, and I was hoping that we would get estimated breeding values quite quickly. it's been quite apparent over the last few years that the estimated breeding values are going to take years. Okay, so then I looked at the functional grading system, and maybe I thought we could start off with this and just teach general practitioners to do the functional grading, and we can use that as a screening test. All the information for this is on the Cambridge website. So if you Google Cambridge and BOAS, you'll see the different research tools we were using and some of the different information that we have published. So this is the functional grading system, and I think this is super useful in practice. So what we're doing with this is we are separating the BOAS from a linear scale into a categorical scale so that we can basically analyze it and give owners and breeders a little bit more information. And we have 0s and 1s, which we say are clinically unaffected, and 0s have got no noise at all before or after exercise when you listen with a stethoscope. The grade 1s, you can hear mild noise, so you can only hear it with a stethoscope, and they don't really have any dyspnea or respiratory effort. And we said the 0 and 1s were unaffected because the 1s don't seem to have any impact on quality of life, and you could exercise them very well. And they also read quite low in the plasmography box. So 0 and 1s seem reasonable as unaffected. The grade 2s have got noise that you can hear without a stethoscope. So any dog that you can kind of look at and you can hear it breathing without a stethoscope is automatically at least a grade 2. Okay, but grade 2s don't have much respiratory effort at all. The grade 3s have generally got severe stertor or stridor, so really obvious and loud, and they've also got respiratory effort. And the respiratory effort is really what differentiates the 3s from the 2s, and you can see it quite clearly. Now, this is now a functional grading scheme which we run with the Kennel Club. And it's interesting, when you introduce people to this scheme, the 0s and the 3s are easy to identify. So there might be a little bit of movement on the 1s and the 2s, which makes sense. But the 3s are universally picked up by practitioners. So this is good, right? So we can pick out the most severely affected dogs. Now, the respiratory noises that we're looking for are the stertor. You know, I've been giving this lecture for years and I still find that upsetting. It's remarkable. This is the stridor. So that's the pug stridor, and then this is the nasopharyngeal stertor or nasal stertor in the Frenchie. So quite distinct noises, okay, and this is what we're going to use to grade our dogs. Now, when we're listening to these dogs, we're listening over the side of the larynx. We're not pushing up, we're listening very gently over the side of the larynx. I like the head to be in a neutral position, okay, and you do get some breeders that will pull the dog's head up and keep it nice and straight, and what they're trying to do is pull the soft palate out of the remiglottis, and that's fine. I just wait, okay, just give it time. The head will be dropped at some stage and you can listen, okay. And then we trot the dogs, and it's a slow jog. It's 3 minutes at 4 to 5 miles per hour. It's a slow jog, and the idea with this is that you are increasing the upper airway demand, and by putting in the exercise test, we massively increase our sensitivity of diagnosis of BOAS from about 40 to 50% up to 90%. Okay, so that exercise is really important. This is what we do the exercise for. We saw too many of these dogs, so a little bit of noise at rest. That, to me, that's a bit of nasal noise, or nostril noise, nothing exciting. This is after 3 minutes. And then half an hour later, this dog was completely relaxed in the consult and has nothing, okay? And pugs are particularly good at disguising their airway disease. So you have a pug, it's sitting on its owner's knee, it's nice and relaxed, you might not hear anything. You take it out and exercise it, and you can suddenly get this really awful airway noise. And that doesn't mean it doesn't have it and you've stressed it, as some of the breeders used to tell me. That means it has airway disease, okay? So the exercise test, I think, is really useful. I like to exercise them myself. A, it keeps me fit. And B, you get quite a lot of information from how much they're regurgitating, or if you see them mouth breathing early. And typically the big bulldogs tend to switch at about 2 minutes, okay? So I can almost use the exercise test and how quickly their breathing changes to realize how severely affected they are, okay? So I do think it's worth exercising yourself. Now, obviously, any dog that comes in with really noisy breathing at rest, you're not going to exercise, okay? So if it's already dyspneic and struggling at rest, then there's no point exercising it at all. But for any dogs that are looking okay, you want to make sure that they generally do have a decent airway. Okay, and again, the functional grading is all on the Cambridge website. Now, once we've got this information and we've got this way of testing the dogs, we could then have a look at some risk factors. And for all the breeds, the nostrils are a really important risk factor, which is why we bang on about the nostrils so much. We're not saying the nostrils are causative, okay? So we are not saying that if you have narrowed nostrils, you will always get BOAS, and the narrow nostrils have caused BOAS. And we do see some really annoying Midland Frenchies that have got really narrowed nostrils and perfect breathing. Okay, so there are dogs out there that have got narrowed nostrils and really good breathing, not so many. And we do see sometimes, unfortunately, some dogs that have got open nostrils and still are bad breathers. Okay, so it's not causative. I suspect that the nostrils indicates what you've got behind the nostrils. So I think probably it's an indication of what's happening in the nasal cavity. So nostrils is first. In all the dogs, having excess body weight makes your breathing worse. It affects your tidal volume, particularly important in the pugs. Okay, so pugs are particularly likely to get worse breathing with increased weight gain. And if you can drop an obese pug's body score, you can often make the breathing a lot better. So we've developed this pug body condition score table for the breeders really and owners, because we didn't find it easy to body condition score pugs with the WSAVA scheme because of the wrinkles around the neck. So this is very much a visual scheme, and we're now saying that we don't want to see the 8s and the 9s in the show ring. Okay, so from this we've managed to push those dogs out in the show ring, and the judges have to record the body condition score now of the dogs that are winning. Other risk factors: nostrils is top in all the breeds. And then for the Frenchie, it is the muzzle length and the shorter and thicker neck. So we like the really long-necked Frenchie. And in the Frenchie and the Bulldog, the males are more affected than the females. In the Bulldog, it's the wider and shorter head. So we're trying to get these old-fashioned Bulldog types back where you have a brick head. It's an oblong head. And a thick neck in a male Bulldog is a pretty bad sign. And there's a cut-off if it's over 0.7. The ratio between the neck girth and the chest girth, that's a real risk factor for having BOAS. So the thick neck is a real risk factor, and that probably reflects the width of the head. Okay, in the pugs, it's the googly eyes. So we like the pugs to have their eyes set close together and be facing forward. And the wider the head in the pug, the worse likelihood they are to have BOAS. Now, it's important to say that the conformational factors only account for about 50% of the risk factor for BOAS. Okay, so there is a big genetic component as well, and the conformational factors help, but you're not going to get rid necessarily of all your BOAS if you have dogs that look better. Now, we have launched this grading scheme as an official health scheme, and it's the RFG scheme. And we're saying at the moment you mustn't breed your grade 3s. So the grade 3s are out for their own welfare issues and also for progeny, and the grade 2s are only to bred with the grade 0s and 1s. And you can find all this on the Kennel Club site, and we have RFG assessors around the country, and you're welcome to come and join us. It's a day course that we run around with lots of pugs, Frenchies and Bulldogs, and it's free. So there's nothing really to lose with this. Now, although this scheme was designed for the breeders, I use it in all my dogs, and I'm using it to audit my surgical cases. Okay, so I like to make sure that all my dogs are graded prior to surgery, so I know how severely affected they are, and also if I've made any difference after the surgery. So what else can we do? So we're going to look at the history, clinical signs and the functional grading which we've discussed. The whole body barometric plethysmography is lovely, but it's very time consuming and it's quite expensive. So to me, that's not something you're going to use in practice. We do have radiographs and CT, and then we have endoscopy, and I really think rhinoscopy is a nice thing to use. It all depends on the owner's budget. Okay, so my most important diagnostic test is always my functional grading, and if the owner doesn't have the budget for anything further than that, great. You know, we can still go ahead and do something. It's just that not all the dogs respond as you would like them to. Now, the clinical signs, we're looking for excessive respiratory noise, exercise intolerance, collapsed cyanosis, regurgitation and vomiting, sleep disorders, and excessive salivation. We have a number of dogs now that are silent regurgitators, so they might not be producing food the whole time, but they're gulping a lot. And then these are the sleeping disorders. So you get these dogs that will choke themselves awake frequently during the night. And then we have other dogs that will sleep sitting up, which is totally abnormal. Excessive daytime sleepiness. And then we also have these guys that are sleeping with toys in their mouths to make sure that the mouths are open so that they can avoid this obligate nasal breathing that dogs do when they're asleep. Now, CT imaging, it's useful. And obviously, this is a nice imaging here where we can see a clearly quite nice pug on the left-hand side. And then we've got some severely affected pugs here. And this is a very hyperplastic thick palate here. And yes, from this, I could say to you, this one looks far more affected than the dog on the left. But there isn't really a cutoff for how thick the palate is in each breed or how long the palate is to be affected. And nobody's really done dimensions of the base of the tongue yet that would make a difference to the prognosis. So the CT is quite nice, and you can give the owner some information, but it often doesn't change what you do. Okay. And sometimes the CT really isn't that easy. So one of these dogs is severely affected and the other dog is completely unaffected. And actually it's A that's severely affected and it's B that's completely unaffected. 9-year-old dog, beautiful dog, this one, completely the size of a whale and a great airway. And I'm not sure I'd be easily able to tell you which was which. Okay, so the imaging is useful to some degree, but will certainly not give you the diagnosis. If I was going to prioritize imaging of the head or imaging of the chest, I would go for the chest. And the reason I would do that is because it would make me more likely to alter what I'm going to do. And if the dog's got obvious aspiration pneumonia, I'm probably going to wake it up and hold off for a week or two. Okay, so it will change my surgical decisions. Other things we look for are a collapse of those main stem bronchi, which you're typically seeing in the left cranial and actually right cranial as well now in the pugs. Occasionally you do see things that change what you do on the imaging. So this is a little pug that's come in as an emergency, and it was a hot July day and the dog's got really quite bad BOAS, and I missed clinically the fact this dog had a lung lobe torsion because you couldn't hear it. This is a left cranial lung lobe. It's tucked right underneath the axilla. So I could not pick this up clinically with a really severe BOAS condition as well. Okay. And then this is a young pug that looked quite nice and had signs of BOAS. And this is a nasal benign tumour called a hematoma. And this actually was why the dog was showing clinical signs at quite a young age, in spite of actually looking otherwise very good. I do like the rhinoscopy, and I particularly like to evaluate the nasal cavity. And probably if I was going to choose between rhinoscopy and CT, I'd probably choose rhinoscopy. Okay, so I think rhinoscopy is a really good idea. It gives you an idea of how obstructed that nasal cavity is, and will complement your clinical diagnosis beautifully. So which are your surgical cases? Well, for me, the grade 3 severely affected dogs are surgical. And then I tend to operate on the young grade 2 dogs. So this is a disease that's progressive. So if you have a dog that presents of a year of age, it's only going to get worse. So the young grade 2 dogs, and particularly those with regurgitation or sleep disorders, because I think the morbidity associated with those two conditions is high. So this is your typical affected Frenchie. So you've got stertor and stridor there, and you've got marked abdominal rest. This is a grade 3. And what are we going to do? So this is what we're up to these days. So we've got the folding flat palatoplasty, which I'll mention. And then I tend to take out the alar folds, and then we do the trader's technique. So this is a bit of a radical neuroplasty, but I like it. You know, you get a really nice airflow after this. And then at the larynx, we take off the cuneiforms. And you can do it bilaterally or unilaterally. I started off unilaterally. I'm now using a bilateral cuneiformectomy for dynamic laryngeal collapse. If that doesn't work, then we go up to the nasal cavity and we do the late, so the laser assisted turbinectomy. I generally do the other surgery first. And the reason I do that is because many dogs don't need the laser assisted turbinectomy, the late. So you might be over treating. And also, if you do the surgeries separately, to me, I get much less morbidity. Okay, so the first surgery is always the worst as far as recovery. The laser turbinectomy is generally very benign for the animals. It sounds invasive, but it's minimally invasive, actually, doing it all through a scope. Many of them are day patients. And if you've done the nostrils first, it's much easier to fit your equipment up the nostril as well. So you have less morbidity and it's a little bit easier, and you can often get them in and out in a day. Okay, so there are reasons for me to split the surgeries. Now, this is an interesting question. Is there any benefit in opening nostrils in puppies? At the moment, there's no proven benefit, apart from in Shih Tzus. And Shih Tzus, I think, just have nostril occlusion. Okay, so Shih Tzus, yes, fine, particularly if they're blowing bubbles out of those nostrils, but probably not in the Frenchies or the Pugs or the Bulldogs, or not that we know about at the moment. And the nostrils do change over the first year, so I'm not sure I would be happy to operate at 3 months and think that was it. And we do see these dogs with no clinical signs and narrow nostrils, so you're also probably going to over-treat some dogs. So I'm not a fan at the moment of opening those nostrils at a really young age. Now, I like to set my own expectations. So we know from having measured these dogs before and after surgery that most dogs are improved. A few dogs go from severely affected to unaffected, but the majority of them go from severely affected to moderately affected. Okay, so we're making an improvement, but we're not curing them by any ways, which makes sense, right? You're only taking a little bit of tissue away from what is quite an unpleasant condition. Some dogs have got very little response to conventional surgery, the palate and the nostrils, and I think it's quite easy to detect those dogs in your clinical examination. So those dogs typically have the nasal and nasopharyngeal stertor, and they're the ones that will struggle to nasal breathe through 3 minutes of exercise. So at least you can warn those owners that, I'm sorry, your dog's got an obstruction here. It's not so easy to treat. We're going to try this, but if it doesn't work, then we do have other things available. The dogs with a worse prognosis tend to be those that present very young, so around 6-7 months of age, those in a slim body condition because they haven't got the exacerbating factors of being fat and they've still got bad airway disease, and laryngeal collapse. Okay. And I do discuss dogs that come in at a very young age. I do discuss it very carefully with the owners, whether they wish to proceed, because you are looking at probably not the best outcome, lifelong morbidity, and a very expensive bill. Okay, so this needs to be discussed really carefully with owners if you're getting these very young dogs with severe clinical signs. What can we do in the hospital? Well, we are minimizing stress. What I really like to do is evaluate the dogs a couple of weeks before their appointment, put them on any medications they need, and then have them in the morning of the surgery and take them straight through to theatre. So they're not sitting around in kennels, they're not being messed around with too much. I like trazodone. I think it works really well in the stressy Frenchies. And then sometimes they do need their props, okay? So we're not really meant to take things into the hospital, but if dogs are using toys as sleep aids, then they do need them. Yeah. And what about surgical preparation? We're giving them omeprazole preoperatively, and typically if they're regurgitating daily, then we will give them omeprazole for 3 to 5 days before the surgery. If they're not major regurgitations, we'll just give it the day of the surgery. We are pre-oxygenating, we're giving steroids at induction. I'm using 0.2 mg/kg of dexamethasone. I'm using a well-cuffed ET tube, and the ET tubes now, we're lubing them because you get a better seal. So I tend to go for a slightly smaller tube and I lube it so that I'd cause less trauma as I go through the larynx. And then the post-op analgesia, I'm giving local nerve blocks, so I tend to go relatively light on the post-operative analgesia. It's often just paracetamol with a buprenorphine if I need it. And I try not to sedate these dogs post-operatively. Now, what about the regurgitators? These are my tricky cases. I lose most of my dogs through aspiration pneumonia if I lose them. And it's these guys that I worry about, and they're just gulping quite frequently. So they're not obvious regurgitators, but you can see it when you watch them. Okay, I'm sorry, this isn't working, but he's a real gulping dog. So we're giving these guys preoperative omeprazole, and then we are also using metoclopramide and then giving them a CRI of metoclopramide during the surgery. And then we're using meropitant or ondansetron to try and prevent them feeling nauseous after the surgery. And I think cisapride works quite nicely as well. It's not the easiest to get hold of, but it is quite a nice prokinetic. I'm not sure about feeding yet, so I'm not starving them as much as I used to. So I'm trying to give them a little bit of food 6 to 8 hours before the surgery. And then sometimes I'm giving them a little bit of food at the end of the day because I think you settle the stomach more. Okay, so it's a really tricky one. We haven't got all the answers for these, but these are the cases I tend to struggle with. Now, you can read very clearly your difficult cases, okay? So typically your emergency cases, any bulldog or French bulldog with laryngeal paralysis, laryngeal stridor is an issue, okay? So this is quite a tricky case. Your frequent regurgitators are also tricky. I think the really stressy dogs are also difficult. And then there was a nice risk study by the Canadian guys, and they had risk factors including previous surgery, which makes sense, and inappropriate low body temperature, which was interesting. So you can pick out your severely affected dogs. Now, what about anaesthesia? We do pre-med these guys, but we observe them after pre-med. So we would not walk off after pre-medding them for obvious reasons. I don't think it matters too much what you give them. They all affect the respiratory function, but we wouldn't give atropine anymore because I think that does thicken up your secretions. I'm using maxillary nerve blocks. And then I also use Otravine, typically at induction in all my cases now, whether I'm doing nasal surgery or not, because it improves your nasal airflow. And we'll talk about that. And then an intravenous induction agent. I think we now have enough evidence that we need to be very careful about your duration of anaesthesia. So there's been a couple of really good anaesthesia papers published in the last few years, and what they've shown is that the complication rate, both during and after surgery, is affected by your duration of anaesthesia. And this is often things like regurgitation. And it's actually quite worrying for me. So it's something like every additional 15 minutes, you can increase your complication rate by 10%, your anaesthetic complication rate. So I tend to try and split my surgeries now. Now, it depends a little bit on what the dog's doing. So if the dog has no regurgitation, I'm a little bit less worried about this. But if the dog is a frequent regurgitator, I really don't want to combine surgeries. So I used to do this kind of thing. This dog's coming in for BOAS and I'm also whipping off his nasal fold. And now I will try and stagger these because even whipping off his nasal fold is still half an hour surgery. Okay, so I think you're better doing the airway first, and then coming back and doing other procedures that are elective at a later date. Now this is Otravine. So this is xylometazoline. You can buy it over the counter from a pharmacy. And this is a alpha-3 agonist, and it shrinks the nasal mucosa. And it does this kind of stuff in about 3 to 5 minutes. Okay. And I tend to drip it in with an intravenous cannula just over my turbinates. And I do this now, obviously I need to do it if I'm going to do any laser turbinectomies, but I do it even if I'm just doing an oral surgery, because I think, well, I'm probably going to cause a little bit of palate swelling. So wouldn't it be nice if they could breathe more clearly through their nose? Okay, lasts for 8 hours. And I think this is a really nice drug. I'm trying to encourage everybody to use it. So even any dog, any brachy dog that's anesthetized, particularly a Frenchie, you know, why not make their recovery a little bit easier by giving them a little bit of a clearer nasal airflow? I preemptively trach. So if I think I've got a really horrible larynx and the dog is severely affected, then sometimes I'll put a trach tube in at the time of surgery rather than watching them recover in a really unpleasant way. And this is just because I watch so many dogs, and I just thought that initial tricky recovery bit where you think they're okay, you're not sure, you don't know whether to leave the hospital. If you do leave the hospital, you're on tenterhooks overnight. Some dogs can manage when they're awake but can't sleep. I just don't want that anymore. We're quite relaxed about the trach tubes, and we manage them very well. So if a dog is severely affected and I think it's going to struggle on recovery, I just take it away now and we trach them. And then there's a few things on surgical setup. I love wearing my loops. Now, it might be an indication of my age, but I do find it a lot easier with a bit of magnification, and then the light goes right down into the back of the pharynx and you can see clearly what you're doing. The other thing I like is this multifunctional arm, which means that you can pull down very nice with the tongue depressor and get a best exposure. If you don't have access to this, just use a sandbag, but really do crank down on that jaw, particularly in the male Frenchies, because some of those guys, the mouth doesn't open very clearly because you've got the temporomandibular joint quite close to the bulla, so you do need to push it to get your exposure. Surgically, I'm taking out the tonsils first, and I do this because I think it reduces some of the bulk of the tissue in the pharynx, and also because I want to close the palate over to the tonsillar crypt. Okay, so tonsils come out, it doesn't matter how you do it, you can do it any way you wish. Okay, and then we're at the palate, and typically I'm now doing a modified folding flap. There are a huge number of different methods for reducing the size of the palate, and there are lots and lots of different papers on this, and to be honest, nobody has really proved that one technique is better than another. Okay, so all these papers will say that, you know, histopathologically they do well at the time of surgery, but there are no long-term studies on different methods of doing the palate. I use this technique. I think this is quite pleasant because you do strip out the thickness at the back of the palate. And also the other thing I like is you're addressing any vessels at the time of surgery. So you're going to avoid any hematomas on recovery. So I like this. And this is what I was saying about, I take the palate now over to the tonsillar crypt. So there's nothing hanging down at the back of the back of the pharynx, and we're probably cutting even shorter than this now. So we're probably cutting and finishing so that we are mid-tonsillar level. These are my images from Naiche, again, who is a beautiful artist as well as being very talented in lots of other areas. It's nice when you work with people that are better than you are. It's great. So when am I using my folded flat palatoplasties? I'm using it on all my bulldogs and on most of my French bulldogs and most of my pugs, to be honest. Not all my pugs. Some pugs have a beautiful thin palate. This is what they look like when they've all healed. Advantage, I think you have easier recoveries, if I'm being honest. So I think you get a nicer post-op recovery. And on CT, it looks great. Okay, so if it was me, I would rather have this than this. Okay, so this dog we have CT because we've done a turbinectomy, and this is one of my palates. Okay, which didn't make me feel great. So the length is perfect to me, so nice and short. But I wasn't exactly happy with the bulk of the palate. Okay, so this is what we can manage now, and I think there probably is an advantage to doing this, but it's not proven. Okay. Then moving back a little bit, so we're back at the larynx now. So we've got that stridor again. And we've got the laryngeal collapse. We go from a grade 2 laryngeal collapse here with the cuneiform processes touching or overlapping, and then the grade 3 when the whole thing collapses. And what I'm doing is I'm treating them by addressing the primary factors, so palates and nostrils. I think in the pugs, the larynx often is the primary factor, unfortunately. And then the next thing I generally do is a cuneiformectomy. And if that fails, then I move to the retinoid laryngoplasty or a permanent tracheostomy. And just to put numbers on this, I've done well over 100 cuneiformectomies now, and I've done about 6 retinoid laryngoplasties, and I've probably done about the same number of permanent tracheostomies. And often the permanent tracheostomies have been done because the owners didn't have the budget to stage it. So I'm holding many of these larynxes with the cuneiformectomy rather than having to do the permanent tracheostomy. I definitely take the laryngeal saccules out because if you leave it, you're leaving them. Okay, they do not regress. They're not going to settle down. You're not making this dog a perfect airway. Okay, so anything you leave there is left. And I'd rather take the hit at the time of a surgery about complications rather than leave the dog with a longer term poor outcome. And I'm also not convinced that they make any difference to complications, if I'm being honest. Okay. So there are a couple of papers out there that suggest that they do, but for us, it doesn't seem to be a strong indicator of whether you're going to have a regurgitator or not. So this is the cuneiformectomy. So this is a unilateral. So we cut off the cuneiform process here, and this is what it looks like bilaterally. You're not making the epiglottis any bigger, but you are stopping the dynamic collapse of the cuneiform. Okay, and I think it's quite. This is actually Norwich Terrier. I think it's quite a nice technique. Okay, now. That's enough of me. When I start messing around with the larynx, I always prep them for a trach. So I've got the neck clipped up just in case. And I always think I might have a rocky recovery, but this is a little dog we did this week. Bilateral cuneiformectomy. This is her on recovery. And it was so smooth. This is her the next day, and she went home. Okay, so I guess I've got it in my head because of many of the dogs have got the worst airways, have got the laryngeal collapse. It's always going to be tricky, but some of them now are really doing well with this technique. And again, I think it's just minimizing trauma. Just to remind you, bulldogs, French bulldogs can get laryngeal granulomas, which sit just behind the vocal fold. So if you've got a French bulldog that you've done surgery on, the dog regurgitates frequently afterwards, and then it develops stridor and it hasn't got stertor, you want to be thinking maybe it's got a laryngeal granuloma. And these respond really well to being removed and then having steroids. Now, this is my nostril technique. I've got this from Gerhard Ochtring at Leipzig. It's a little bit radical, I accept. It doesn't look the prettiest initially. And we're also taking out this alar fold. So we initially cut medial to lateral, and then we go around and we get rid of this chunk of tissue here. Okay. And then you do the trader technique afterwards and they bleed. Okay. And to stop the bleeding, we just put in cotton buds with a little bit of adrenaline on them, and the bleeding will stop in about 10 to 15 minutes. So it's incredibly rare that I still have a dog with any nasal bleeding once the dog is extubated. Now, why do I do it? Well, this is, it can go a bit crusty, it can look a bit unpleasant. And this is the wedge, which looks much nicer, much more cosmetic. But this is a wedge resection that looks quite good externally. But you can see the scar there. But then when you scope the dog, so I'm looking for the turbinates now, and I'm going in the nasal cavity here. This is the alar fold. and the alar fold goes all the way back. Okay, so there's a good centimetre and a half of alar fold there. So, and there's the aberrant turbinate. So I don't think many of the wedge techniques are that effective. And when you've done this technique, you can literally look up into the nasal cavity. So you definitely get rid of the nasal obstruction. And they look nice afterwards. The other reason I did it was because I was seeing too many of the dogs I'd operated in the show ring. And once you've done this to a dog, it is so blatant that you have operated on the nostrils. Recovery, we go really slow. So nice slow. We typically take 15 to 20 minutes to recover these dogs. The tube comes out as soon as they have their head up and they start to swallow. I like them to be at normal temperature, and they always have an emergency kit ready for them, which has just got a smaller sized ET tube in there and some induction agent. Nebulized adrenaline, super nice. So for your dogs that are struggling a little bit on recovery, then we're using 0.05 mg per kg of adrenaline, made up in 5 ml with sterile saline. And we're using these small handheld nebulizers, and we've shown with the plasmography that this does drop your obstruction quite nicely. It's also useful for the pugs before the surgery as well. So we can certainly try it in emergency cases, but after surgery, for any of the dogs that are looking a little bit tricky and are having a bit of effort, it's definitely worth doing. Now, we're typically often keeping them in for 12 to 24 hours. I'm now starting to believe that some of these dogs that are very stressy, like this guy, are actually better if you send them home the same day. So this dog, 8 hours after his surgery, looking great, much happier with his owners overnight than he's in hospital. And I think the stressy dogs are really tricky to manage sometimes. So I think if you've got a dog that looks great, you've got a good owner, and they're not too far away, then I think there's a lot to be said for getting them out of the hospital. If I've operated on the airway, sorry, on the larynx, then I do keep them in. Okay, so laryngeal dogs I'm not brave enough to send home yet, but some of the stressy Frenchies where it's just palate and nostrils, I get out. We're sending them home on low-fat food and typically just using paracetamol, and many of them are on omeprazole. Again, some of the regurges we can't get under control easily in hospital and have to go home and just see if you can settle the regurgitation there. You can see when you look at the plasmography traces that we make a difference with the surgery, but unfortunately not a massive difference. So many dogs improve 10–20%, but we're not making them, from severely affected many to unaffected. And the prognostic indicators, again, we've mentioned slim body condition, age of presentation, laryngeal collapse, and the surgical technique. So for me, I'm better with the new neuroplasty and the modified folding flap than I was doing a wedge resection and a staphylectomy. Now, if the surgery doesn't work, and this is typically those nasal dogs, then we do have another option. So we've done a beautiful folding flap, we've taken out our ventricles, we've done the nostrils, and we still have an obstructed dog. Okay, so now we're going to hit these turbinates, and we're doing the late procedure. And the late procedure, you're using the Otravine first to shrink the turbinate tissue, and then we're going to use a scope. So it's all minimally invasive with suction, and we are cutting away this ventral nasal concha. And this can go really well and be done in 20 minutes, or it can take a good hour or two. And the problem is I can't always tell which one. The good news is the only person that tends to suffer from this is me. And the dog's generally doing really well. Most of these dogs are in and out in a day. I've never had to transfuse one. I was listening to somebody the other day saying, oh, 30% had major, hemorrhage. And you think, well, not for me, major hemorrhage as in it's obscuring the nasal cavity. But I don't understand really where that came from, because you just pack it and then come back to it. So we're not having to transfuse these dogs. We're not seeing major blood loss. Typically a day patient, but can be a bit frustrating for the surgeon. And this is what you do. So you're removing some of the turbinate tissue, giving them a better nasal airflow here. And you can see it also sagittally here that you've got more black airspace there. The owners think they are better at exercise afterwards. They're only slightly quieter. You don't necessarily get rid of noise with the turbinectomy, but we can treat the regurgitation and the sleep disorders. So I'm typically using this for dogs that are still regurgitating and having sleeping issues after surgery. Clinically, you do find a reduction in respiratory noise, interestingly, particularly the stridor. So that laryngeal noise reduces. So that would suggest that some of the laryngeal noise in the bulldogs and the Frenchies is maybe secondary to this nasal obstruction. And you get an improved respiratory functional grading score. What I do quite like is we don't go near this area at all with the laser. So this is right at the back of the choaney. And this is the mucosal lining of the choanine, and it shrinks after doing a late. So you're taking out the turbinates and you shrink this area here. And I think that's maybe an indication that with the really obstructed nasal cavities, you do have very excessive nasal air pressures. You do get regrowth, and this regrowth is good because you do want to have turbinate tissue. You need it for heat and exchange, and you also need it for humidifying that air. But the obstruction doesn't come back in the same way. Okay, so you don't get the same degree of obstructive turbinates. And we can also see here that if you treat them with the late, then they do respond quite nicely. So this is our cohort here that had the first, well, this is before the first surgery. We improved them after the first surgery. So they've gone from about 90 to about high 60s, 70s with the BOAS index. And then after the late, we can get them down to about 40%, which is clinically unaffected. So it does seem to give additional value or improve the airway in the right cases. Okay, this is my favourite case. I've got others now, but this is still one of my old favourites. Thank you very much for your time. You can find me at Hamilton, so if you've got any queries or questions, you can also email me there. Okay, thank you very much.